So with that being said, let's talk a little bit about some of these bilevel devices over here. So this is going to be probably the hardest question I have here. So this is a 72-year-old man with hypercapnic COPD. Started using BiPAP in spontaneous and time mode, so he could actually trigger the BiPAP, or it's going to be scheduled time for the respiratory rate during sleep. He reports feeling as if his device is breathing for him before he's ready to breathe in. So he's not even ready to breathe in just yet, and the device is giving him another breath. So he still wants to breathe out, and there's another breath coming in. And no one should be surprised that feels horrible, because he has what? COPD. And COPD, you want to have a long what? Yes, expiration time. So he probably wants to blow out more than the average Joe. You know what I mean? And what's happening? Another breath is coming in all of a sudden. That's got to be awkward. He also reports more frequent awakenings during sleep since starting the use of the device. So this is really bugging him. Which of the changes to the patient's BiPAP settings would be most likely to improve his dyssynchrony? So these are tricky ones. We're going to spend some time on this. Should I increase the inspiratory time? So what does that mean? Is that give him more time for the breath to come in? That just sounds mean. Why? Because when you have COPD, I don't know how bad it is, but if you're hypercapnic from COPD, I'm sure the FEV1, the forced expiratory volume in 1 second, is going to be pretty low. So he wants to breathe out. So if you give him more time to breathe in, he's really going to start what? Air trapping. What do we call it? Auto peeping. So I wouldn't increase his inspiratory time. If anything, I would decrease it. So A is wrong. But I lengthen the rise time, which means that if you on BiPAP, there's a certain pressure you have to reach. The rise time is going to be how long it takes to reach that pressure. So if you want to spend more time on expiration, you want to actually shorten the rise time, not take your sweet time to get to that pressure. So once again, increasing inspiratory time, lengthening the rise time, both these sound opposite of what you want to do with someone with COPD. C, increase the cycle sensitivity. So not everyone who's watching this is a pulmonologist, but these are terms I use when I, are managing people on ventilators. So when we talk about cycling the vent, that's going to be what actually terminates a breath. So if you actually want to increase the cycle sensitivity, you're going to terminate the breath earlier, which kind of makes sense because you want to actually terminate the inspiratory breath earlier so they have more time for what? Expiration. So I kind of like the concept of that. And if you folks can't really understand what I'm talking about, we're going to really dive in deep for this question in a second. And D, increase the triggering sensitivity. So of course, all these CPAP and BiPAP mean that you have to trigger the breath. It doesn't seem like there's any problem with him triggering the breath. If anything, he's triggering it too easy, you know what I mean? But I don't think we have to increase the triggering sensitivity. So I think this is the hardest question you're going to get in regards to, non-invasive ventilation. But the answer here is going to be what? C. So really love this. So this is going to be a BiPAP, non-invasive. What are we showing here? This is pressure on the y-axis. This is the patient triggering the BiPAP. Remember, spontaneous mode and time. These are spontaneous breaths. This is the pressure going up. Everything above this dark blue dashed line is inspiration. And of course, what's going to shut off the breath is right here, is going to be what cycles the vent, this straight red line. And we'll talk about that in 1 second. So this patient had something called dyssynchrony. The patient wasn't synchronizing with the way the settings work. So what are things that we can do? So I'm just going to be talking about one breath. So it's going to here's a bunch of breaths. Here's just one breath right here. So we said triggering. So notice that there's no trigger right here. If the patient was triggering, you would trigger here. How do you trigger the vent? You could trigger it through flow. Flow is volume over time. There's a flow trigger or a pressure trigger. You could generate a negative pressure and it triggers a breath. Then we don't need to do that for this sensitivity for this patient. The rise time is how long it takes to get to the maximum pressure support. So this is the rise time over here. The inspiratory time is now that you reach that pressure you set, let's say it's a pressure of 15, how long do you stay at that pressure of 15 is the inspiratory time. Then right here is how you turn off that breath. What shuts off that breath? And of course, when we talk about cycling for pressure support, that you do that based upon the what we call the flow cycling, and we'll talk about that, where you want to increase the cycle time. We'll show you what that means. So since this is pressure, what's going to be what you generate? Volume. Since this is pressure, what you generate here is volume. VT stands for tidal volume. So just to once again show you what I mean, in the answer choices, if you want to increase the rise time, what does that mean is that it's going to actually take longer to get where you are. And if it's going to take a longer time to get up there, that it's going to actually take the rise time, which is this red line here, and go to the right. It takes longer time to get to the peak pressure. If you shorten the rise time, which is a better choice, it will actually shift it to the left. Just increased rise time, you get the pressure you want at a faster rate, so you have more time for expiration. And then inspiratory time, so the red is going to be the normal inspiratory time that was set in the vent. If you increase the respiratory time, you shift this to the right, which you don't want to do in COPD. If you decrease the inspiratory time, you shift to the left, which is kind of what you want to do for people with COPD to give you more time to breathe out. And the last is going to be the cycling, increase the cycle sensitivity. So what does it show is that everything above this line here, so let me go back, everything above this dashed blue line is inspiration. And we said that you cycle at this point here. So what happens is when the patient is generating the tidal volume, which is the flow of the volume over a period of time, is that when you get 40% is left in the breath, you could cycle off. Or if 25% is left in the breath, you could cycle off. Or if 10% is left in the breath, you could cycle off. So what you want to do is to actually stop inspiration earlier so you can get more time to blow out. So you're going to do what's called increase the cycle sensitivity. And that was going to be the answer right here. So if you increase the cycle sensitivity, that means you'll cycle off earlier and not later. And if you cycle off earlier, you get more time for expiration. So I wanted to mention a couple of these advanced airway modes. And I don't know if it's just you folks, but I'm like, oh my God, it's already been an hour. So let me just go a little further. I'm sorry. I just really am passionate about this, so I apologize. So when we talk about bilevel, there's AVAPs. And the key thing about AVAPs that you're thinking about it in someone who's hypercapnic, obesity, hypoventilation syndrome, neuromuscular diseases. And this is volume assured pressure support. For my pulmonologists listen to this, for invasive ventilation, it's kind of like the PRVC, pressure regulated volume controlled. So what are you going to dial here? You're going to pick a tidal volume. So let's say in these individuals that after they fail something like a bilevel, spontaneous and timed, and I really want to blow off the CO2, I would dial in a tidal volume of 500, and the pressure supports are going to adjust to make sure I get that tidal volume. And what do I set? A pressure support min and a pressure support max. And it's going to adjust this pressure support to give that tidal volume. And of course, it's a bilevel device. So the AVAPs is the inspiratory pressures, and EPAP is going to be how do we treat the apneas. So of course, we have an EPAP min, EPAP max to adjust for the apneas, and the inspiratory breaths are going to be AVAPs. Good for blowing off the CO2. ASV, really its claim to fame is when we talk about central apneas, and really its claim to fame is conceptually when we talk about things like Sheen-Stokes respiration, secondary to CHF. This is really a good way to stabilize the CO2. So if someone is very hyperpnic and they're taking big tidal volumes, it's going to lower the pressure support, so you won't get big tidal volumes. And if you have tiny tidal volumes, what is it going to do? It's going to increase the pressure support to give you more tidal volume. So it's good for stabilizing the CO2. So once again, ASV is a bilevel device. The inspiratory breaths are ASV, and the expiratory breaths are going to be PEEP. And what do we use this expiratory pressure to eliminate the obstructive apneas?